Hi, everyone. So my name is Megan Chaigneau, and I have two different jobs. The first is that I'm one of the nurses with the Inherited Bleeding Disorders program in Kingston. And the second job is that I work as part of the research team with Dr. Paula James, who is also out of Kingston. So Natalie Filbert at Hemophilia Ontario, she was present at WFH last spring, and she heard me give this presentation about some work we've been doing around hemophilia related testing in young girls. And so she asked if I would give the same presentation with some little updates that we have from last spring. So that's what I'm here to do today, and I will get to it. So the project is called Exploring Changing Beliefs Regarding Hemophilia Related Testing in Young Girls, Perspectives from Parents and Healthcare Providers in Canada. So the only kind of disclosure that we have that's more of a thank you is that this project was funded by the Canadian Hemophilia Society through their Novo Nordisk Canada Psychosocial Research Program. So we are very grateful to them for supporting this work. Before we get started, I have a little disclaimer because in this presentation, we will be using sex and gender specific terms such as women and girls and female. And we do this intentionally to highlight the unique symptoms and experiences and care gaps for this population because they have been historically overlooked with regards to hemophilia. But we want to acknowledge that these terms are exclusive and also recognize that many experiences also apply to all people with the anatomy that allows for menstruation, including transgender men, intersex people, and gender non-binary individuals. So a little bit of an introduction. I think it's pretty well acknowledged now that historically women have been viewed as only unaffected genetic transmitters of hemophilia. They were often referred to as silent carriers, but research in the past 3 decades has shown that quite clearly, that women are affected in a variety of ways. So they can be individuals who have hemophilia corresponding to their factor level, whether that's mild, moderate, or severe, or if for those with normal factor levels, they can be either symptomatic or asymptomatic hemophilia carriers. And that's in line with the new nomenclature that's been released. Now, women and girls who are affected by hemophilia have been shown to experience both underdiagnosis and delayed diagnosis, and this often, unfortunately, results in missed or untreated bleeding symptoms. So as research about women in hemophilia has evolved, testing recommendations also evolved. So when we first started having factor level testing, it was really only considered prior to pregnancy. But since then, many new testing time points have been considered. And so really like any number of the ones that you see on this slide might be given out. So that's early childhood, in the event that abnormal bleeding symptoms present prior to a procedure, around the age of menarche, so when a girl is going to get her period, at the age of consent. And currently where we stand is that we don't have any national consensus on testing recommendations, and there really isn't clear international consensus either, although some groups have published recommendations. So that's the background, but the main reason why we started this project was that a few years before, we had carried out a different project with hemophilia carriers where we held focus groups with women across Canada who were carriers. And what we did is we really just asked what they saw as the knowledge gaps and the challenges that they were facing. And so one of the topics that came up was that we heard a lot of frustration, disappointment, and even anger with the current testing situation in Canada. So these women who participated in that study, they reported inconsistent recommendations across HTCs, instances where testing requests were refused, and also situations where delayed testing resulted in untreated symptoms and preventable bleeding. So we thought this was really important, and it wasn't something that we had really had on our radar before, but we wanted to do something about. So we came up with this project, and we had three main objectives. So the first was to really do a deep dive into the evolution of beliefs and testing practices about women in hemophilia, to figure out when did things change, how has this changed over time, where are we now, and what are the current recommendations that are being given out in the literature. And then the second part was that we wanted to simply describe the current recommendations and practices of Canadian hemophilia treatment centers. And then finally, the third was that we wanted to hear from parents and families and be able to describe the experiences of Canadian parents as they made these testing choices for their daughters. So in order to do this, we kind of had a mix of different methods. So for that first objective, which is describing how things have changed over time, we did what's called a narrative review. So we did a deep dive into the literature, really focusing in on beliefs about women in hemophilia and testing practices. And then for those objectives 2 and 3, what we did is we talked to two different populations. So for the healthcare provider perspective, as I am a nurse and a member of CanHC, we went to the Canadian Association of Nurses in Hemophilia Care, and we sent a short 5-question survey just asking everyone, what are the treatment recommendations? What are the current testing recommendations being given out at your center now? What do you tell people when they ask about when should my daughter have testing? So for that, there's 45 nurses who are affiliated and they represent the 23 HTCs across Canada. And we had 26 responses collected for that. And then for the last objective, what we did is we talked to parents. So the inclusion criteria was any parent of an obligate or potential hemophilia carrier of any age residing in Canada. And we had distributed some recruitment flyers through the provincial hemophilia societies. So for this part of the study, we carried out structured interviews with a total of 14 family members, and it was all done over either telephone or video conferencing. So that's what we did. And then this is what we found. So again, going back to the different objectives. So that objective 1, we carried out this narrative review of the literature, and it was pretty interesting. We went all the way back to the early 1800s to the present time, and we were focusing in on what were the prevailing beliefs about women in hemophilia and the testing practices. So it's not going to surprise anyone, but the most long-standing view or belief documented is this role of females as genetic transmitters, so seen as hemophilia carriers. It is noted in the very earliest descriptions of the disease, and it continues until this day. Whereas contrastingly, what we now know about females having an increased risk of bleeding, this isn't something that was really noted or acknowledged until around the 1990s. Now, they also did find a lot of evidence much earlier, as early as the 1920s and 40s, showing that women can have abnormal factor levels and can have abnormal bleeding symptoms. But this, despite that evidence, it didn't really become a true widespread belief until this 1990 time point. So it's not surprising that when we finally get to this point of seeing women as possibly affected by hemophilia, there was simultaneously the first suggestions in the literature that females should be routinely assessed for factor level as a way of evaluating bleeding risk. So prior to this, factor level testing had sometimes been done in women, but it was mostly related to carrier identification. It wasn't really done as a way to assess bleeding risk. It was more about trying to figure out who was a carrier and who wasn't, because they didn't have genetic testing yet. So although the view of women as being affected with hemophilia is relatively new compared to this long-standing view of women as genetic transmitters, it's not that new. So it's been about 30 years since the first major calls for routine early testing in women are documented. And so I have a quote here from one of these papers, which is from the WHO, and they said, like, all potential carriers should be tested early in life to determine factor 8 or 9 activity levels. This should be done for safety reasons alone to protect individuals who may have bleeding problems in certain situations. So that was sort of like the main finding on the evolution of testing recommendations, is that in 1990 is when we really start to see this recommendation that it be done routinely for all females potentially affected for safety reasons to assess bleeding risk. Now, one of the things I didn't share in the original presentation, but I can share now, is that I gave you a tiny snippet of this objective one. But for anybody who's more interested, we worked with a number of giants in the Canadian bleeding disorders world to write up a full history of women in hemophilia, where we go through a lot more of the beliefs and testing practices. So for anybody that's interested, they can read the paper here. It's open access, anybody can get it. But it goes into a lot more detail. I gave you just like a little snippet. But that was objective one. So now when we get into objective two, so as I mentioned a little while back ago in the methods, we sent a survey to CanHC nurses across the country, and we just asked, what is the usual recommendation of your HTC on the timing of factor level testing for obligate carriers? And then the second identical question was about potential carriers. And so we gave everybody multiple time points, and they could select more than one time point if they wanted, and that's how you get those combo categories at the end. There was also an option of writing in your own recommendation if what we gave you didn't fit best. So this is what we found for both obligate and potential carriers. So for me, primarily, when we got this data back, what I saw is that the results align with what we heard from the community, from the parents in the previous study, and that is that recommendations really do vary across the country. So if we go back to that, when I was talking about objective one, and I said in 1990, there was this call for systematic early factor level testing for safety reasons alone. So when we look at that recommendation and see how many HTCs are giving it out, for obligate carriers, it's only about 27%. And then when we move to potential carriers, only 15%. So most HCCs are recommending a combination of time points. So for example, if abnormal bleeding symptoms present, otherwise at the age of consent or prior to pregnancy, those were some of the most commonly reported advice that's being given out. Now, there were 4 centers that recommended factor level testing in early childhood for all carriers, but that would very much be a minority out of those 26 responses that we received. So then we moved to the topic of genetic testing in minors. So this issue is more ethically complex, as genetic testing is often reserved when the person often reserved until the person in question is old enough to give consent. But it's important to note that in the genetics community, it is very routinely considered earlier in age if it's to the medical benefit of the child. So in light of research that carriers can have bleeding, all carriers, particularly heavy menstrual bleeding, genetic testing for hemophilia has been increasingly considered in girls who are under the age of 18. Additionally, there's a fair amount of evidence in the literature that there tends to be a parental preference for earlier genetic testing. And so in order to capture this, we presented what is a not uncommon scenario where a family asks for genetic testing of a potential carrier who is under the age of consent, and then we just asked what would be the usual response of your HTC. And so again, what we saw is similar to factor level testing in that there is like a pretty wide spread of recommendations that are being given across the country. But we did see that there's almost a majority who would approve a request for genetic testing if the family fully understood all the implications and abnormal bleeding symptoms were present. So now I'm moving us along to objective number 3. And so this is when we actually talked to parents of girls who were potential or obligate carriers. So we carried out 14 structured interviews. And now I always say that I could talk about their stories for a full hour, but I don't know if everybody would want to listen to me do that. So what we've done, particularly for this presentation, is that we kind of concentrated it into 5 key themes that I'll come back to: this parental desire that parents are just trying to protect and promote the health and well-being of their child. So I've labeled that safety first. So number one, safety first. Parental decisions around hemophilia-related testing center around wanting to promote their child's well-being. The knowledge is out there that girls can have low factor levels, and so it's just seen as very logical and important to have an early baseline factor level. We heard that diagnosis equals treatment, and so some of the recommendations around delayed testing, we heard about how that can actually feel like it's harmful to the child and that it's not in their best interest. Because if you don't know that, say somebody, a young girl has mild hemophilia, then you can't really treat accordingly. In the words of one mother, I just wanted to be as prepared as possible for the health of our daughter. Now, another reoccurring theme we labeled the need for knowledge. And within this theme, what was highlighted was the really important role of adult hematologists in disseminating information on testing for young girls. And what was interesting is that this is where, we have our inheritance pattern for hemophilia. So a lot of our dads out there, they're going to have daughters who are obligate carriers, and who they're going to ask for advice is their adult hematologist, their adult HTC. And then another thing within this category was that we noted a lot of misunderstanding and lack of knowledge around how factor levels can be influenced by things like birth, traumatic blood draws, age, medication. Families described being told that the results were not accurate, but they couldn't always recall why. And there was lots of knowledge gaps around when and why retesting might be needed. So one of the quotes that we pulled out for this category was that it came from a dad, and he said, I sort of knew it was a possibility that she could have bleeding issues, but I didn't know it could be mild hemophilia. The language of symptomatic carrier was very misleading. I was led to believe that the levels would be normal but low, so I felt very surprised when my daughter was diagnosed with mild hemophilia. I felt almost lied to. Now, this third theme that we pulled out is something that we labeled parental responsibility. And so this is where parents feel like they are responsible for differentiating what is normal versus abnormal bleeding. And this is mostly related to when we give out testing recommendations that center around, oh, like it's not needed unless she has abnormal bleeding, then it puts it up to the parent to figure out, well, how bad is too bad? When is something abnormal bleeding? And this was noted as being harder for families who live far away from an HTC or who have a very limited relationship with an HTC. So they don't have someone that they can go to say, okay, my daughter's having a nosebleed that lasts this long. Is this often? Is that normal? Is that abnormal? So the quote that we pulled out for this one was, we took out the name, so it says, daughter, my daughter did have a lot of mild bleeding. It was a lot of pressure to determine what was bad enough to be considered abnormal. I mean, they always clotted eventually. It took longer than their mom, but of course was faster than me. This is a person with severe hemophilia. It was just really hard to know if this was bad enough to take her in for testing. And then another theme that we pulled out is something that we labeled generational trauma. And I think what we intended for this is to encompass the fact that many families have personal experiences of bleeding symptoms being dismissed and undertreated in their mothers, aunts, sisters, and grandmothers. So diagnoses of mild hemophilia in female family members often arrived very, very late in adulthood after these women had already experienced significant bleeding, whether that's heavy menstrual bleeding requiring hysterectomy, undertreated postpartum hemorrhages due to a lack of diagnosis. So families with this type of history are very likely to be strong advocates for earlier testing, both factor level and genetic, as they just want to prevent these same negative experiences from happening to the next generation of girls in their family. So the quote that we pulled out here was from a mom, and she said, even though my symptoms weren't severe compared to the boys, I didn't hemorrhage, they still had negative consequences. My bleeding always went on for so long, heavy periods, bleeding after tonsils and wisdom teeth removed. It just would have been better with treatment. A lot could have been avoided, and I don't want that experience for my daughter. And then the last theme that we pulled out from our parent and family interviews was just this idea of clear and consistent. We heard repeatedly that families just want clear and consistent recommendations that are the same for everyone. And the quote really captures that. And this is from a mother, and she said, "Everyone should have the same access to testing and get the same advice." Now, whenever doing research, we do like to acknowledge the limitations of our study. So two of the limitations that we talked about when I gave this presentation initially is just something called selection bias. We put out a flyer about parents who wanted to talk about testing experiences and testing choices for their young girls. And so it is somewhat likely that parents who felt strongly about the topic were more likely to respond to the recruitment poster, and that might have led to more negative experiences being documented. There are likely lots of families out there who had positive experiences. They felt no issues with the timing of their daughter's testing, and they didn't respond to the recruitment call. And then the other limitation is that, I mean, it was kind of intentional. It's not necessarily a limitation, but we really focused on the Canadian perspective. We wanted to know what is happening here in Canada. Now, the updated outcome for this is that I think I gave a bit more of a thorough description of these two objectives than I did for the narrative review. But if anybody is interested in more information, we also published the full results in the Hemophilia Journal. So I've put the title here. And again, it's in open access, so anybody who'd like to learn more can go and look at that. Now, the conclusion of the presentation that I gave at WFH was we really just said that we highlighted the need for national and international testing guidelines with clear testing recommendations. And we brought up the European Association for Hemophilia and Allied Disorders, EHAD, and that they've already done this in the European context. And what they recommend is systematic assessment of factor level testing and bleeding phenotype during early childhood with repeat testing before menarche of all females from hemophilia families. And then the recommendations around genetic testing was that genetic testing of potential carriers should be offered when they're competent to understand the results, with testing in childhood considered when clinically relevant. And the last point that we added was just that we firmly believe all guidelines should incorporate family experiences and preferences. So I kept this thank you slide up because I really do want to thank all of the research participants, the CanHC nurses, and all of the patients and families who responded. For us who are doing research, I mean, it really, really helps, and we appreciate it so much, and we want to do things that are useful. And so hearing from the community is so important, and having that community involvement. Now, that was the end of the presentation that I gave at WFH. But before I finish up this one, I wanted to continue with some things that have happened since then. So as I mentioned at the beginning, I do the research side of things in affiliation with Dr. Paula James, who's a wonderful researcher out of Kingston. And many years ago now, she created this website called Let's Talk Period. Now, I could talk about Let's Talk Period also for an hour, but, and I do have to give a little plug for something called the Self-BAT, which is a self-bleeding assessment tool where patients can go on and you take a quiz and you can find out if your bleeding is abnormal or normal. But for this, what I want to highlight is instead of clicking on Self-BAT there, and this is a screenshot from the website, if you go to Let's Talk Period and you click on Resources, the next screen that you'll see looks like this. And there's tons of amazing resources on here. There's stuff for nurses, patients, primary care providers. And I would encourage patients to click on all the different links. There's a lot of stuff on what is heavy menstrual bleeding, what is abnormal bleeding. But I'm going to direct you to the section on patients. And then it would look like this. And when you get to the patient resource page, if you clicked on girls affected by hemophilia, what you would get is this new infographic that we just made in the past year as a response to the research that I just outlined. So we heard the parents and the patients and the families say they want clear and consistent recommendations. So this is a first step in addressing that knowledge gap around updated testing recommendations. And so we developed this evidence-based infographic along with a huge multidisciplinary team of nurses, physicians, lab experts, genetic testing experts, patients, and families. And you can go on and see the frequently asked questions. But what I wanted to highlight is just this idea that was very intentional in the infographic where we separate out knowing your bleeding risk and knowing your carrier status. So for this infographic, in line with what the European Association has said, we write current guidelines have recommended having a bleeding risk assessment by hematologists with baseline factor level testing in early childhood, with repeat assessments done before menstruation and prior to any major dental or surgical procedures. And we separate this out from also the need to know your carrier status. And this is in line with calls in the literature where it says experts highlight the need to dissociate bleeding risk assessment recommended in early childhood from the genetic diagnosis of hemophilia carriership, which can be assessed later in adolescence or the age of consent. So that's the end of my presentation. I wanted to just thank Hemophilia Ontario for asking me to do this, and especially Natalie Filbert, who does so much for the Women in Bleeding program. So thank you, everyone, for listening.